Welcome, everybody. My name is Dr. Al Heuer. I am the A and A&T lectures, with Terry Shenfield being the T. And today's lecture is going to be on the ABCs of pulmonary function testing. I have to tell you in all honesty that the emphasis on this particular lecture is going to be more on things like flow volume loops and not so much on diffusing capacity and some of the other specialty tests that are done as part of a pulmonary function technologist review. So some of the specific learning objectives, we're going to describe the indications for pulmonary function testing. And it really is, it's a little bit variable because it does depend on, what the actual, the patient, the suspected, if you will, dysfunction may actually dictate what specific pulmonary function testing is actually done. We're going to take a deeper dive into some of the dysfunctions and some of the testing that can be done. Categorize the pulmonary function tests according to specific purposes. So following with the first objective, the second one is getting a little more specific. List the indications for spirometry, lung volumes, and diffusing capacities. Identify at least 3 obstructive and 3 restrictive pulmonary disorders. So for any of you who are interested in taking the specialty exam, or if you need to, re-credential, or quite frankly, for the learners, for the respiratory students who are matriculated in respiratory therapy education programs, almost undeniably, the MBRC exams, both the TMC, the multiple choice exam, which is the exam that you would, a candidate would take to become a CRT or an RRT, or the specialty exam, the C and the R PFT exams. They really want the learner or the one seeking the credential to be able to distinguish between obstructive and restrictive pulmonary disorders. So we'll focus on that as well. Relate pulmonary history to indications for performing pulmonary function tests. And again, a bit less heavy emphasis on the instrumentation and the calibration, bearing in mind that this is about 45 to 50-minute presentation and really have to just focus on, covering a limited amount of content, but doing it in a very thorough fashion. So the major indications, so broadly speaking, pulmonary function testing is done to help diagnose lung diseases. No surprise there. In some cases, it may be very, very useful in even distinguishing between the 2 main categories of a COPD, or chronic obstructive pulmonary disease. So really looking at, a disease such as emphysema will tend to, it's an obstructive disease, as is chronic bronchitis. But one of the differences, or one of the issues that can distinguish them, is that for emphysema, the diffusing capacity will often be lower or significantly lower than normal. Whereas with chronic bronchitis, assuming that there's not an acute exacerbation superimposed on top of it, you usually find that the diffusing capacity is much less effective. So diagnosing diseases and distinguishing between or amongst them. Monitoring disease progression. And I'm picking on cystic fibrosis patients, not to be, in any way discriminatory or anything along those lines, but it's common for individuals who are diagnosed with cystic fibrosis to have what's called serial pulmonary function testing. So 2 or 3 times a year, perhaps if they go into the hospital regularly for 2 or 3 times a year for, let's say, a tune-up, so really more of a preventative visit, if you will, they will probably have a battery of pulmonary function tests that are done when they come in. It'll be done at least every year to monitor and quantify their disease progression, or hopefully lack thereof. To quantify the level of lung dysfunction. So now that you maybe have more specificity on what's wrong with the patient, to say, the degree, if you will, of actual dysfunction. To aid in pre-procedure screening and risk adjustment. So one of the things, so in addition to being a faculty member at Rutgers University and County College of Morris Respiratory Care Program, and obviously working with Terry, I am also involved in as a full-time lead respiratory therapist at a major medical center in northern New Jersey. And they have among other things, they have a very active cardiac surgery program. So one of the things that they do, not just for cardiac surgery patients, but focusing on them for a moment, is they will do, before their surgery, they will do spirometry. So we actually have a portable device where you're doing basically a forced vital capacity, and from that you're extracting different measurements, but including a flow volume loop and the concomitant measurements. And what they're seeking to do is at least two things. Number one is to ensure that the candidate that their lung function is not so poor that maybe they should be excluded. They're too high a risk for the surgery. They're at high risk for higher than, if you will, average, or much higher than average risk for, if you will, experiencing peri or post-surgical problems or respiratory complications. So that's one reason that we would actually pre-screen the patients. The other reason to pre-screen this population of patients is to risk adjust. So outcomes are looked at very, very carefully. Things like, for post-open heart patients, how long were they on the vent for they are extubated? What was their length of stay overall? What was their mortality risk, and things along those lines. And one of the things that can be helpful is if a surgical team are operating on a more risky, a population of individuals that have worse baseline lung function, then it's really unfair to compare their results to another surgical team, perhaps at another hospital, that's operating on individuals that have better lung function. So the attempt by doing the if you will, surgical testing is to kind of try to level the playing field and look at outcomes in more of a apples to apples fashion. So categories of pulmonary function tests divided by or amongst lung function as they measure, different things. They measure airway function, which is one of the main areas. So I bolded and italicized the main foci for today. So airway function, lung volumes, and ventilation. A little bit of discussion on diffusing capacity, blood gases and blood gas exchange tests, of which diffusing capacity is a part. And then we really don't spend time in this lecture, but in other sessions, we do spend some time talking about cardiopulmonary exercise stress testing, as well as metabolic measurements. So it's not unusual if a hospital or hospital system have a team of pulmonary function technologists. It's not unusual for them to be involved in several or all of these particular functions, do metabolic studies with the registered dietitians, et cetera, and recommending perhaps changes in macronutrient mixes, perhaps ones for the COPDers that are less, they emphasize, let's say, carbohydrates less and perhaps fats and proteins more, for folks that have cystic fibrosis, that their fats be absolutely minimized because of their pancreatic insufficiency and their inability to, or their insufficient ability to metabolize fats. So looking and using the metabolic measurements to make those determinations. So a little more specificity on the airway function test. So simple spirometry, doing a vital capacity, which could even be done with the likes of a Wright's respirometer. Expiratory reserve volumes. Now you're looking at volumes, in some cases like, hidden volumes, which can be kind of tricky to get. We'll talk a little bit about those in the ensuing slides. For a forced vital capacity maneuver, which again, for a lot of the bedside testing that's not done in a lab, a lot of the figures that are extracted at the bedside or done so from the forced vital capacity maneuver. Just a quick word, we throw on forced vital capacity, and I did mention Wright's respirometer. A forced vital capacity should not be done on a Wright's respirometer. So there's nothing wrong with using a Wright's, nothing at all. You can't really interface it with a computer system, things along those lines. But it could be a potentially useful tool, but you should not do a forced vital capacity. It should be a slow vital capacity maneuver with a Wright's, because you can basically blow out the veins. You can basically ruin the device by doing a forced. So there's a host of, if you will, bedside spirometers that are available out there. They're technically digital technology that can be interfaced with computer in order to print out things like flow volume loops and things along those lines. Some of the actual, if you will, depictions that I actually have in this presentation. And then looking at, some of the other, pre and post bronchodilator, figures as well. We'll talk a little bit about bronchial provocation or bronchial challenge through the use of methacholine. So we'll talk a little bit about that as well. Tests like maximum voluntary ventilation, or MVV. In some books, it's called MMV, maximum, if you will, mandatory ventilation is another way of referring to it. Maximal inspiration expiratory pressure. So things like MIPS and MEPS, can be done as well. Typically, you'll actually see those more in an ICU or in a long-term vent unit where they're trying to measure and quantify muscle strength. Airway resistance, so measuring airway resistance and hidden volumes via a body box. Things like compliance through an esophageal balloon. And again, esophageal balloons are indeed also used in an ICU to get a better read on what the, if you will, alveolar pressures are. More on lung volumes and ventilation tests, so functional residual capacity tests. So the new learners will ask, well, if you can't exhale functional residual capacity, if you can't get it all out, how do you measure it? And many of us have learned, maybe all of us have learned, this part maybe review, is there's several tests that you can actually do, but it's basically an indirect measurement. Because you don't have the ability to measure directly, it could be a nitrogen washout where the individual's hooked up to, they're breathing through a sealed circuit, and they're basically, breathing 100% oxygen, and the hidden volume will correlate, if you will, to the elimination, the time it takes for nitrogen to be washed out of the system. And then you also have helium dilution, and the time it takes to equilibrate, no helium from an equal state, being exhaled as well as what's being inhaled. That also does correlate with, those hidden volumes. And there's other techniques as well. I don't want to get too bogged down in any one of these slides here, but those are some of the basics. Total lung capacity. So you'd use some of the same tests that you use to determine residual volume and functional residual capacity can also be used as a tool in calculating total lung capacity. Minute ventilation, alveolar ventilation, and dead space ventilation can also be, if you will, determined, but also calculated based on blood gases, based on, if you remember, pico over pico. So you're looking at, the difference in if you will, exhaled CO2, and you can use some of those calculations to determine dead space. And from that, you can calculate things like alveolar ventilation. Closely estimate, I should really say. Distribution of ventilation tests such as, multiple breath, nitrogen, helium equilibration, as well as single breath techniques as well, that some of which use radioisotopes. Diffusing capacity, so single breath, and some of our other lectures, one in particular done by Terry, that really focuses on diffusing capacity close. So really looking at steady state. There's other techniques as well, but in the interest of time, we'll focus on what's listed here. And then blood gases and gas exchange tests, looking at blood gas analysis and co-oximetry. So again, the difference between co-oximetry and pulse oximetry is co-oximetry is using multiple wavelengths versus pulse oximetry using infrared absorption. Co-oximetry is using multiple wavelengths to actually tell you not just how saturated the blood is with oxygen, but how saturated the hemoglobin is with other, I'm going to call them dyshemoglobins. So things like carboxyhemoglobins and methemoglobins and things along those lines. And the other tests that we have here as well, pulse oximetry, capnography, etc. So the patient preparation, so you get a patient come in, again, we have a pretty active pulmonary function testing lab, and patients come in, they schedule the patients from about 7 till, 5 or 6 at night. It's very, very active, actually a revenue generator for the system and for our department. So preparation is certainly important to be able to get accurate tests, get the patient. And when I say in and out, they want to get their test done and they want to get home. So to get that testing done and kind of move on. So some of the things are recommending things like withholding of bronchodilators, withholding of methylxanthines. So you have things like theophylline, which is a side door. If you think back, it's a side door bronchodilator, but it's recommended that methylxanthines be withheld as well. Now, I have to say this, in another one of my lectures where we talk about dispelling myths of pulmonary function testing, there are multiple schools of thoughts. And one of the schools of thought is that, technically caffeine is a methylxanthine. Okay, it's in the category. It's not as potent a bronchodilator as theophylline, which is moderately so. It's not highly potent, but caffeine supposedly does have some bronchodilatory features. And in this other lecture, I basically say that, there's some researchers out there that say, while caffeine probably should be withheld, some of the studies say it really doesn't make a difference. Just know that it's a good idea to withhold methylxanthines and caffeine, but just know that there's some information out there saying if it's just 1 cup of coffee, it really shouldn't make a difference. The leukotriene or leukotriene inhibitors should also be withheld, such as Singulair as well. Smoking, hopefully, I'm a refrained, if you will, or a reformed smoker. I quit about almost 15 years ago now, but I'll always bear that stigma of being a former smoker. But in this particular case, if the patient is currently smoking, that they refrain from smoking for at least 24 hours, which is probably a very difficult thing to do. What they need to do is quit altogether. We all kind of know that. But the idea is that smoking is an irritant and that it would actually, if you took 1,000 patients and they happen to be smokers and they had a cigarette or two before they actually had the testing done, is their results would tend to be a little bit worse than somebody who was, hadn't smoked in 24 hours. With the mindset that the smoke is a irritant. Avoid big meals, avoid caffeinated beverages. I kind of alluded that with the methylxanthine conversation. Alcohol, avoid exercising beforehand because there are individuals that have exercise-induced bronchoconstriction, lose comfortable clothing. If they're in some form of interpreting, when I say some form, some recognized form. So whether it be a phone, interpreting phone, your own phone, or some of the hospitals have different colored phones that do the interpretation, or a certified interpreter. Okay, what is discouraged is using somebody who just let's say a carpenter who's working in the hospital who happens to be bilingual, using the carpenter as an interpreter, but he's hired help. He's not an employee of the system. He's not certified. They discourage that unless there's absolutely, it's an emergency and there's no other alternative means. Preparation, physical measurements, so the things that we're taking, the age as of the last birthday, height, and so height is used to determine, things like, body habitus and predict an ideal body weight, sex or gender, physical assessment, breathing patterns, some of the things that you would assess with almost all of our patients, whether you work in an acute care environment, pulmonary rehab, PFTs, or home care. Some of the other things you're going to look at, current diagnosis or indications for why the test is being done, family history, personal history, if there's occupational, environmental exposure, smoking habits. And today, smoking/vaping habits is really probably the more appropriate terminology there. Cough, dyspnea, and any current medications the patient's on. So medications like beta blockers, for some patients, not for many, but for some patients can be problematic because particularly the older generation beta blockers that, will be like heart rate control medications, beta blockers. They may be less specific to beta 1, and they may be problematic because they also are blocking beta 2, and you may get some de facto bronchoconstriction. So just, asthmatics need to be a little bit careful with those beta blockers, particularly if they're older generation ones. A little bit now, that really is focusing for a few slides here on obstructive versus restrictive patterns. If I didn't say this earlier, I'm saying it now, that it does not preclude the possibility that a patient could have both. They can have an obstructive disorder and they can have a restrictive disorder. Okay, you're just looking at this depiction here. On the left-hand side is obstructive, On the right-hand side is restrictive. So with the obstructive, you're looking at, basically some hyperinflation. The patient's supposed to be exhaling, and that the alveolus does not want to collapse because there's an obstructive disorder. On the right-hand side, you see the restrictive is the alveolus does not even fully expand, because perhaps the patient has, a chest wall issue through kyphoscoliosis, or it's not chest wall, it's pulmonary fibrosis, where the actual lung tissue itself is, if you will, fibrotic. It's more leather-like. It doesn't, it's if you will, its elasticity is very high. Okay, it's very elastic. Okay, which is the reciprocal of compliance, like a low compliance, high elastic, condition. And then real fast, just looking at the gross distinctions between, in the middle there, you have normal. In restrictive, you don't have to be, an expert in pulmonary function testing to say, well, if you're looking at those volumes and capacities, in restrictive, they're typically marked by reduced volumes and capacities. And again, a capacity would be, 2 or more volumes. And then the obstructive patient has the opposite problem. So they have, if you will, increased capacities and volumes. And that's really owing to their inability or not inability, but their reduced ability to exhale. So many folks that have an obstructive disorder have more trouble on the expiratory side of the equation than the inspiratory. So they can breathe in kind of okay, but they have much more difficulty on the exhaling. So what happens is they end up air trapping. They never get the last breath out, and now they're taking the next one in. So it's not unusual for patients that have severe emphysema, which is an obstructive disorder, to really be really significantly hyperinflated, owing to that inability or lack of sufficient ability to fully exhale. Looking at some of the conditions. So that's some of the manifestations, okay, that your restrictive patient will tend to have, grossly speaking, lower volumes and either normal or higher flows. Okay, it's restrictive. Okay, your obstructive patients will tend to have reduced flows but increased volumes. It's a gross simplification. It's not true 100% of the time. And indeed, there are some conditions where an individual can have a condition that is both fibrotic, okay, or restrictive and obstructive. Let's take a look at some of the actual conditions. So obstructive air disease is some of the common ones. COPD. Again, in this particular slide, they lump bronchiectasis into COPD. We can debate that till we're blue in the face. But again, bronchiectasis may actually be a concomitant finding with, severe chronic bronchitis. The patient has repeated, if you will, pulmonary infections, and they have reduced compliance of their airways. They develop pocketing in the actual airways because of the repeated infections, and it becomes problematic. Hyperreactive airways such as asthma, cystic fibrosis. There can be, by the way, a component to cystic fibrosis that's about fibrosis in the end, where the compliance actually drops as well. So it's both a restrictive and an obstructive, but in the mid and earlier stages, it's more obstructive. Larger, if you will, upper and larger airway obstruction, so neuromuscular disorders, obstructive sleep apnea, tracheal stenosis, extrinsic airway compression, such as you might see with someone that has some sort of a chest wall abnormality. You have individuals that have severe morbid obesity, but very profound muscular boundness, things along those lines. Scleroderma, where the actual tissue gets fibrotic because of a alleged autoimmune type of condition. Restrictive diseases, and again, you have chest wall, you have lung. So, some of the chest wall, kyphoscoliosis, obesity, pleurisy, we can debate that. Pleural effusions, you think about, now you have fluid that's, basically compressing, the actual lung. So, it's kind of more in the category of chest wall than actually the lung tissue itself. A pneumothorax, hopefully treated promptly, but a pneumothorax where you now have air that's mechanically compressing the lung. Restrictive lung diseases. So now you're actually looking at the lung, pulmonary fibrosis. The most common causes, it's idiopathic, which means we don't know the cause. and some of the other disorders that we mentioned here, we talk about congestive heart failure. You don't really think of it being an issue of compliance, but where you have fluid buildup with that left heart, that basically the blood is the plumbing system is backing up, and now the blood in the pulmonary vessels, the actual pressure is increasing, and now you can have the fluid that's traversing the alveolar capillary membrane, except it's going in the direction from the vessels into the lungs. So you get the wet lung effect, increased vascular markings that you may see with congestive heart failure. More patterns of neuromuscular disorders can also be restrictive. So I know I mentioned in obstructive, but diaphragmatic paralysis. The patient, it may be that the diaphragm itself has been injured, or the phrenic nerve that's emanating from C2 through 5. Some of the books say C3 through 5. And there's some issue with the cord or the actual phrenic nerve itself. ALS, or amyotrophic lateral sclerosis, or Lou Gehrig's disease, pretty much an aggressive disorder. Guillain-Barré, so perhaps a post-viral syndrome that results in, if you will, increased protein in the cerebral spinal fluid and a demyelinization of the nerves. Myasthenia gravis, so you have a neurotransmitter abnormality that results in a weakness that really, basically often starts in the face and the eyes and kind of works its way out and down. Guillain tends to start in the extremities and work its way up. Lung transplants, so single, double, heart, lung, things along those lines. Some more terms. We'll get into the actual testing very shortly. So vital capacity, the maximum amount of air exhaled after a maximum inspiration. So only in, and then out. And depending upon who you're talking to and what the patient has, if they have an obstructive disorder, the way that I don't say yelling at the patient, say you shouldn't yell, but you're coaching them out, all the way out. So that your vital capacity, your forced vital capacity is obviously a rapid maneuver versus a slow one. In some patients, I will tell you, there's a difference, marked difference between forced and slow. Okay, the idea goes like this. So in patients where the forced is, if you will, much lower than the slow vital capacity, they may well have an obstructive disorder. They warrant, it could be effort dependent, but assuming the efforts were both good, it can be that if you give a COPD patient enough time to exhale, it may take them 7, 8, 9, 10 seconds to exhale that forced vital capacity. They may be able to get it out, but if you have them force it out, the airways may collapse, the equal pressure point shifts, and they may not be able to get it out. It may be considered, the forced version may be considerably less than the slow vital capacity. So that's one of the other comparisons that can be. Force expiratory volume in 1 second, FEV1, the amount of air that's in the first second of a forced vital capacity maneuver. For the average Jane or Joe, that should be in the 75 to 80% range, 78%, a lot of the books will actually say. And it can be a very valid measure of obstructive disease. Even though it says forced expiratory volume, it's really a flow, because volume over time, volume in 1 second, volume over time is flow. Forced expiratory flow between 25 and 75%. The average flow during the middle half of the FVC maneuver can be helpful in diagnosing small airway disease. Other terms, so peak flow, indeed, that's what we may do at the bedside with patients, or train asthmatics to do on their own with a peak flow meter. Peak flow, on the downside, it can be very effort dependent, but for individuals that get good at it and do it at home, it may be a good leading indicator. So the peak flow may drop off considerably before the asthmatic starts feeling crappy. So again, like anything, it's got pluses and minuses, but assuming the patient has good technique, it can be potentially simple, inexpensive, and valuable. MVV, I alluded to that earlier, the volume of air that a patient can breathe rapidly and forcefully over a specified time, often 12 seconds. All right, so we're looking at the relationship here. The significance of this slide, okay, is not just to show you on the left-hand side the relationship between these capacities and volumes, okay, but to give you an idea when you're coaching a patient, let's say even whether it's in a PFT lab or at the bedside, that you're asking the patient, once they're, you instruct them, put the nose clips on them, a good tight lip seal, is you want them to take some breaths normally, okay, normal in, normal out, normal in, normal out, and then a deep in, and then out, 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 out. Again, you can yell at them, you can scream at them, but they're, you don't have to necessarily do all that. Just make sure that the coaching is really what's critically important. It's less about the screaming. You may, instill terror in their hearts by screaming at them. So Lord knows, probably not a great idea to do that, but to really coach them clearly and if you will, authoritatively. Out, 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 all the way out, 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 out. That right there. Forced vital capacity maneuver consists of maximal inspiration, as I said, rapid, forceful, and complete expiration. Physiological factors that can influence the gas flow, mechanical properties of the lungs, so the compliance, resistive elements, so the obstructive elements, and airway collapsibility. Okay, so you get patients that have saggy airways. Okay, patients that have, if you will, emphysema. Other individuals that have, say bronchiectasis, where the airways don't lose it altogether, but they have less tone. They're less firm. They're less able to, if you will, dilate. They tend to collapse more readily. So that those would be some conditions that would have, if you will, higher airway collapsibility propensity. How do you know the test is accurate? There's a lot of time and effort that's actually spent in that, and the American Thoracic Society has guidelines. To take a deep dive into that would actually, really chew up a lot of our time today. But really looking at best effort volume difference, so less than 150 among the top 3. And looking to assess the end of the test, the maneuver must last at least 6 seconds. There must also be, an obvious plateau for 1 second. Inspect the graphic, rule out problems and assess reproducibility. Okay, and again, there's much more elaboration that's on this, and a lot of the handheld digital devices that are commonly used today, it will tell the tester and the patient, okay, but it will tell the tester whether it is an acceptable maneuver or not. Okay, it will say that. It may grade it from A through E, okay, but many times it'll just say it'll be dichotomous, acceptable or not acceptable. Just a spirometer. I'm really not emphasizing. I had some images of equipment in here, but again, because of this is one CEU and we want to kind of get through all of the content in a reasonable span of time, this is just really showing you one of the spirometers that's actually out there. And they actually, it's interesting, they use, you're looking at really the variation in pressure, okay? And if you think about the variation in pressure, it does correlate to flow. And using these capillary tubes, these are very specialized devices that are made, and they tend to be quite accurate, and the equipment is calibrated, PFT equipment is calibrated with a super syringe every day, and that's all documented. So there's different measures that are done to help ensure that the equipment is properly calibrated. When the results, when I took my RPFT exam, they were very big on things like, when you do your quality controls, and when the numbers tend to shift, they're within acceptable range, and then they shift out of the range, identifying what it's called and identifying, what are some of the potential problems and how you fix them. Gets really, really a deep dive. And if I didn't say this earlier, the RPFT was probably the most, it was the most difficult credentialing exam I took. I have the ACCS and some other exams or credentials, like probably many of you, but the RPFT was a toughie. And then looking at some of the actual waveforms, some of the graphics, if you will. So forced vital capacity, first looking at a volume time curve. Okay, so it's anytime you look at a graphic such as this, or a graph, it's a graphic, but it's also a graph. Okay, on the vertical axis, you have volume. So, just its relationship If it's a 2-axis graph like this, it's looking at the relationship between two variables, in this case, volume and time. And the volume time curve, might be seen during the forced vital capacity maneuver. And the advantage of it is that its ability to view small changes in volume as the maneuver ends, thus helping better detect, the end of the test. So there's advantages to it as well. And then you can see, where you're out now, it looks about 9 seconds, where you actually have the line has pretty much become horizontal. It's leveled off, but it took about 9 seconds to get there. Hence, the maneuver really needs to be a minimum of 6 seconds for an adult patient. And then the infamous flow volume loop, which again is available or is producible from a lot of the bedside digital devices. They will actually show you the display, not just in the computer, but the actual device itself will probably show you a flow volume loop. And you actually have, the lower portion of it is the inspiration, the upper portion is the expiration. And this is more closer to a textbook demonstration of what you'd actually see in a relatively normal flow volume loop, the shape of this. I say that because we're going to go, we'll look at a few that are not, that would be classic but abnormal. So preparation and testing, again, a patient prep, as previously noted earlier in the presentation, instruct on the maneuver, use as simple terms as possible, again, account for translation if that's necessary, demonstrate the maneuver. Of course, you're not going to put your lips on the mouthpiece, but there's ways that you can actually demonstrate it effectively. In some cases, you can show videos and things along those lines. Coaching and encouragement, use enthusiastic, active, forceful coaching. I don't know if that's their nice way of saying yelling, but they say don't yell, but forceful coaching to help the patient perform the maneuver. May need to raise your voice, some urgency, blast it out, blah, 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 blah. They tend to close the door in our pulmonary function testing labs. We have more than one room, but you can still hear right through the door. It sounds a little like a torture chamber. You're not sure what they're doing in there. I don't hear any, bumping and crashing, but you hear a lot of, I'm going to call it yelling, or as we said in this slide, forcefully coaching. The testing technique maneuver should have, rapid maximal inspiration. This is after the patient's, breathing normally for 2, 3, 4 breaths. Submaximal inspiration result in reduced numbers. A lot of the equipment today is pretty darn good at determining if it's a poor maneuver, or if the patient maybe is trying to, if they're qualifying for disability, they may be, they're not doing it properly, and they've done it a number of times. So maybe they're deliberately, probably not, by the way, but maybe deliberately trying to show a lower number than what it really is. Blast out is set hard and fast. Continue to complete exhalation. Within, maneuver acceptability, good start of the test, no excessive hesitation. Back explanation is one of the ways to really determine if it's a valid effort, if you will. No cough in the first second, no variable flow. And then if the early termination of the exam, you'll actually see, instead of it coming down to like a kind of a flat line very gradually, there'll be like a cutoff. And then obtaining at least 3 acceptable maneuvers, and taking the highest of those 3, by the way. Another example here. So this there's a little more graphic where it's actually, pardon me, showing you, where FEF 25 is, where FEF 50 and FEF 75. You can see that a lot of the, this is a flow volume, but a lot of the volume is in fact blown out in that first second, okay, in that first second. And, the other perhaps interesting thing is that relationship between forced vital capacity and what percentage of that forced vital capacity can be exhaled in the first second is a big determinant of how, obstructive disorder versus someone who doesn't have an obstructive disorder. And again, the key, it really is a range, 75 to 80, but if you're looking for a number, about 78% of the total forced vital capacity should be exhaled in that first second. And then some, again, MBRC loves to ask questions like this. When I taught respiratory full time, we really like to take a look at, well, what do some of these disorders look like? And just, I'm not going to cover each and every one of these, but I will show you a few. Like, let's take in the top center there, emphysema. Okay. So the dotted line would be, well, this is would be a relatively normal flow volume loop. Okay. The emphysemic patient there, what's different is, if you look at it, the flow, okay, is never as great. Okay. So we say is the height. The flow is the height. Okay. So for that top middle, the flow is crudely is probably 60% of what the normal dotted line shows you there. Okay. The other thing is the actual volume, which would be the horizontal axis, is longer. Okay. And it's carved out. So as the patient is exhaling, they reach, if you will, peak, and then it's kind of carved out. Okay. It's longer and it's carved out, and that's certainly suggestive of an obstructive disorder. Okay. Whereas top all the way on the right there, what's significant is the volume's reduced because it's a restrictive disorder. All right. But you actually have, the flow itself will tend to, it's less, but will tend to reach peak flow more quickly. Okay. Because the stiff lungs or stiff chest wall want to, if you will, contract back to their resting state more quickly. And then you have different variants of that on the bottom there. So you have a fixed upper airway. So you have the one all the way bottom right that kind of looks, it looks small. It looks pretty equivalent from inhalation to exhalation, which would be one of the characteristics of a fixed upper airway obstruction. And then you have some of the others that are listed here as well. Again, time precludes us from drilling down too deeply in those. And then you have here your a volume time relationship, and showing you on the top in magenta, I'll call it the normal curve. And then you have in the blue, you basically, what you're seeing is it's just your volume over time. Your flow, it takes longer, much longer to reach, if you will, that plateau. And the restriction, it's actually, your flows are, reached much earlier on, but they also level off at a lower level than either the obstructive or the normal. Comparison of some of the efforts here. So this is just, it's the sort of thing that you might see from a computer printout on if you're worked in a pulmonary function testing lab. So you have, basically, the best of these, if you will, the best of these. The FEV1, so the third number down, FEV1, the forced vital capacity percentage, they're all kind of north of 80%. So they're, actually slightly better than what you'd have the flow slightly higher. But it gives you an idea that basically these numbers here all within a very limited amount of variability. Okay, and based on the limited variability, you would then, assuming they're all acceptable maneuvers, you would take the highest of each one of those. Classification of severity, as we kind of start winding down here, there's a little variability depending upon which book you look at, but when you look at FEV1, so again, some of the books will say that 80 to 120 is normal. Okay, some of them not less so. They'll go, they'll drop it down to 70%. So for, a vital capacity mild obstruction of the FEV1, if it's greater than 70%, then you go from 60 to 69% moderate, and you work your way all the way down to, if it's, to the bottom there, very severe obstruction, FEV1 is less than 35% predicted. Reversibility. So what is done fairly commonly in a in a lab is looking at doing the patient's spirometry, and then you give a bronchodilator. Not uncommon to use a metered dose inhaler or dry powder inhaler, and then you wait. Ideally, you would actually wait, in a perfect world, you'd wait like 30 minutes, but typically they're waiting like 10 to 15 minutes, and then they'll actually do it again and check the patient's responsiveness to the bronchodilator. So it's post value minus the pre-value. And then you have the over the pre-value, will give you that times 100 will give you the percent change. And again, depending upon which book you look at, some of the books say if the percent change is 12% or more, it's significant. Some books say 15%. I've seen it a few times listed at 10%. So it's just something to be mindful. It's in that 10 to 15, roughly 10 to 15% range that would be classified as a significant improvement, if in fact it is. In some patients who are very debilitated, understand that even if the change is 5, 6, 7%, the idea is they're so debilitated, their asthma, their COPD is so bad that any improvement, okay, is deemed worthwhile getting them on the regimen. Reversibility testing, so a little bit more on the the example here. So the example given, if you go to the bottom, the forced vital capacity, or let's look at the FEV1 on the very bottom there. The pre was 1.82, the post is 2.07, and it's a 14% difference. That's borderline significance. The one above it is 16. So that would be significant, not hugely significant, but it's significant nonetheless. Interpretation, so you're looking at your reference and your predicted values. So your race specific values, and they have the NHANES, 3 reference values recommended. Airflow limitation, where you have a reduced forced vital capacity, FEV1. In one of my other presentations, we look at some case studies where we take this out of the abstract and we actually look at some cases where this stuff happens. With a restriction, reduced forced vital capacity, FEV1, but the FEV1 to forced vital capacity ratio is normal or even elevated in some cases. The elevation will come because the lungs or chest wall want to expand, or rather want to contract back to their resting state. You can get some times where it's actually the actual flow is elevated. Bronchodilated response, as I said here, 12% by many textbooks is regarded as a significant change, with a little bit of variability depending upon which book you look at. Peak flows. So again, I mentioned that some of the advantages and disadvantages to using peak flow. They're still recommended to be used, but you have patients who, let's say, are asthmatic and they're able to 80 to 100 of the personal best. They're in the green zone. The yellow zone is 50 to 80, and then less than 50, patient may be in trouble and may either be not feeling well, or maybe headed in that direction, and just everything hasn't yet caught up with them. So some take-home points: pulmonary function testing can be very valuable. A monitoring tool, especially for patients with chronic lung diseases, to monitor, how severe their disease is. And then a separate but related point is, if they've had serial pulmonary function testing, how much worse it's gotten, how their disease has progressed, if you will. They can also help screen the patient who is high risk for unsuitable certain procedures, such as surgery. And then, as I said earlier, can also be very useful in doing the risk adjustment. However, it's important to keep in mind that specialized equipment and training is required to obtain and interpret the results. So, like a lot of things, the devil's in the details. And it's, you need the ability to, the equipment and the personnel to, the individuals to know how to use the equipment, which is functioning properly, and also know how to coach the patients so that we can optimize the results that we're getting. So selected resources, one of them is this piece that I actually love. It was published in the Canadian Journal of Respiratory Therapy, 2017. It talks about debunking myths in pulmonary function testing. Basically, interesting piece. If you're interested in reading more on pulmonary function testing, I highly recommend it. Of course, I had to put some plugs in for my textbooks. The Egan's Fundamentals of Respiratory Care. We have a nice chapter that's done by Zaza Cohen, one of our colleagues who works in one of the hospitals here, but he was at University Hospital with Terry and I, who ran the Pulmonary Care Fellowship Program. He does a real nice job with the pulmonary function testing chapter, as he does in one of my other textbooks, the Clinical Assessment of Respiratory Care in 2019. So with that, I want to thank you all, for attending today's lecture. Hopefully you got something out of it, and we hope to see you soon. Thanks again.